Hospital Board of Directors meeting. Our vision is providing quality care close to home. Everybody knows this meeting will be on video and our audio recording. First thing I'd like to say is call to order. Do we have a quorum? Yes, we do. Okay. I'd like to ask everybody here that try to stick to the schedule where they have the cafeteria and food and everything. Let's try to stay right on course right here. Public comment. Do we have any public comment? I don't hear anybody with public comment. Okay. The minutes from the last meeting. I would like to ask for an approval of the minutes.
Approved.
Okay. All in favor? Aye.
Aye.
All opposed? Okay. The March employee of the month, Troy Mason. David Walker, you want to?
Yes, let me introduce Troy Morrison. He's not here today. He's out sick. But Troy was nominated by 2 staff members for the following reasons. From the first day on the job, Troy hasn't stopped. He arrives ready for the day. He helps out in all departments. Whatever is needed, he is very positive, makes sure jobs are completed properly. He's very professional, and he's all with a smile. Troy is a very good worker. He always doing items on his list, plus any other things that come up. He is courteous to everyone and takes pride in the work he does at Weems. Troy works in our maintenance department, and he has really been a joy to work with here. And he's not only taking care of the hospital, but he also takes care of the clinics as well as EMS. But he is not here today, but we want to recognize him for a job well done.
The next item is the foundation update.
All right.
Bill and Ms. Zester, take it away.
All right. I'm going to introduce my wife, Colleen Zester, who's the chairman of the foundation board and been doing a lot of work on this. I just report it on a regular basis, but I'm letting the boss come and speak.
Smart guy. All right, so David's passing out just 2 summary slides. I ask you not to read ahead, if I may.
I'm sorry, you got to do it.
Hello. Okay, so I'm Colleen Zester. I'm the acting chair of the Healthcare Foundation, as Bill Zester said. Here to give an update. Since the hot wash meeting that we did in January regarding the health fair that took place in November of last year, no reading ahead, co-chair over there, Mr. Zester. We took into account all of the feedback that we received from the November health fair. Quick shout out to Robin Paulson and the whole team that really spearheaded the November health fair. It was a lot to build that from the ground up. There was nothing in place. Robin and a really great team did some important work. Our biggest learning, I think, and I'll look to you, Robin, tell me if you agree or disagree. I think our biggest learning was we did all of this great work. Unfortunately, we chose a date that was in conflict with some other things that had already been on the calendar. So that was our number 1 learning. We took that into account as we're planning for the health fair. Just real quick, for the health care this year, our foundation goal is to align our area of focus with the hospital's stated need and goal. Therefore, all of our fundraising proceeds this year will be directed to outpatient care and services that are provided through the hospital. We have 2 primary events and then what we're calling 2 secondary events that we're planning for. The first primary event is the May 18th health fair. As I noted, we have basically taken the same format that was done for the November 23 health fair, and we've changed the date to May 18th. I'll go into that in a little bit more detail. And exciting, a little bit of a drum roll, we are doing a 65th anniversary gala for the hospital. We're planning that for November 9th. A little more detail will come as well in a few minutes. Our secondary events to help not only generate awareness, but to potentially generate some funds to support all of our efforts this year. June 21st, 1959 was when this hospital opened its doors, and thus the 65th anniversary. So our plan is to do some kind of on-site staff appreciation event and we'll build that with Robin and David and the team. But earmark that date, really give it the credit that it's due. Also use that as an opportunity to start generate awareness and start selling tickets for the gala.
Say it again.
Which part?
The date.
All of that?
The date.
Of the gala?
Yeah. Well,
That'll
both,
be
yeah.
November 9th. I'm going to go into more detail in a few minutes. And at the printout that you were given, there's details on that too. But thank you for not reading ahead. So that's June 21st. And then the other secondary event, July 3rd, we know that there's a big waterfront celebration here in town. It draws a huge crowd. There's opportunity for us for a nominal sponsorship fee to have a table there. Our thoughts are to use that as an opportunity again to generate interest and awareness in the gala, also start generating some fundraising efforts, and formally kick off ticket sales for the gala at that time. Any questions before I go into the health fair? No? Okay. You all can see back here because you didn't get a handout. I didn't bring it. That's my apologies. All right. So on your handout, please look at the side that is about the health fair. We'll start there. Okay. So this will be our second annual Catch the Wellness Wave Health Fair. I'm going to pause for a moment, ask you all to do two things when you leave here today. Number one, any social media posts that you put out there, please use hashtag Catch the Wellness Wave. Anything you do, that's going to start to generate some social media traction. I'll email out the details to you following the meeting as well. And the second thing, for those of you who happen to be on Facebook, how many people have Facebook pages? Facebook. We, the foundation, now have a Facebook page, and we're also linked to the hospital website. We have a section, thank you to Robin and Christy for help with that. We have a section on the website. But if you would, time permitting in your day today, please just go onto Facebook, and if you just go into the search bar and put Weems Foundation, it should pull up our Facebook page. We're going to ask you please to like us, but optionally follow us. What that's going to do,
Weems Foundation.
just put it right in the search bar, right, Bill? That's what we tested. Weems Foundation. It should take you right to our page. Then if you can follow us or do what you're comfortable with, but then that allows us to grow our social media base.
But
Every
just-
time we post something, it pushes out broader.
Let me just help you one. So when you go in and you share and follow us, you can share some of the things that are going out from the health fair, from the foundation. So the foundation is pushing out different ads about things that are coming up. You can share that on your Facebook, and that will draw your people who are on your Facebook to the foundation as well. So that's how we're getting larger social media population to be seeing the foundation information.
Precisely. Any questions?
I don't know how to do that. I mean, I don't
I'll
know.
help you. I'll
Just
help you.
put share? Okay.
Yeah.
Basically, when you type in
I don't-
Weems Foundation, it'll take you there.
I
and
just
then
look
there
at the
literally you
granular
can say,
mostly on my
well,
face.
okay, there, I'm friends with you. I'll help you.
Well, we are, but I, you know.
But there's a button that'll literally say follow, like, whatever. You just press the button. It's pretty
Okay.
simple.
Maybe
Okay.
you can show me and give me a little.
I
training.
sure will. But there's just a little
Could I,
30-second commercial.
when we're talking about this, absolutely, we aren't putting the word out good enough. You know, you're starting to, this initiative here. But I've got something embarrassing this year. I have a little routine ultrasound every 3 to 5 years. Check on everything's fine, everything. So I go to my doctor in Tallahassee. He said, "Yeah, it's time for you to get this. We're going to analyze it." So make an appointment, drive back to Tallahassee. On the way back, after the drive to Tallahassee, which is around an hour and 45 minutes,
Oyster Radio.
go by Costco and spend a bunch of money. Go by Bass Pro and spend a bunch of money. And probably about $300 or $400 lighter plus drive. It hit me that we have ultrasound. I had to come right here.
We have what?
And I'm
Ultrasound.
ultrasound. You know, it just so somewhere when we're thinking the health fair and stuff, we need just a bullet of all the services offered at the hospital. Every service that we offer.
Okay, I think,
You know, every single service that we offer. You know, here I am, the chair, and I drive to Tallahassee when I can come right here. You know, and it just didn't dawn on me. And we're offering more services than we ever have.
Sure.
So some little flyer that would go, a
Sure,
simple listing, maybe an explanation of, you know, we don't, you know, ultrasound, everybody knows what it is. Maybe we're doing things people don't understand, a quick explanation.
Well, I think you're right, but I think that's not the foundation's duty to do. That's really Christie, who's our PR people,
I was gonna say-
and/or Weems Hospital to put it out on their
Blocks of
website.
information, the same blocks of information could be put in several places.
It can go there too, you're right, but I mean, we need,
No, we'll put that out. And ultrasound, you know, we've been having ultrasound here. I think Amanda was employee of the month, probably into a board meeting. You can probably clap hands before. That's Amanda Bird, that's the ultrasound person, that we have here. But we definitely would develop certain things, you know, about all of our different services. But the foundation, the old foundation, you know, they were instrumental in getting an ultrasound machine here for the hospital. But we definitely would begin to amplify that message more of all of our services out there. So we'll definitely do that.
I just think that by all means, by every channel that we have, just to
Absolutely.
get that information.
Yeah.
You're right, Bill, you're absolutely right.
Yeah.
It is that, but we need it to be simplified, where somebody can look at it, not 8 pages long, just a bullet point. That's the type of stuff I read.
Yeah. Yeah, I've been in
And
touch
bam,
with.
that could help.
We'll get you one of those so you don't have to drive to Tallahassee.
Thank you. It's for me, okay? It's for me.
Also, you know, if you look at our stuff that we sent out and make sure the service on there. And next month, Christy Terry, the marketing person, she will be here also to give an update on the different things that she's been doing.
No, I mean, it's just don't.
Well, your point's well taken.
Offers some of the services we offer.
Sure. Sure, I think the point is
That'd be good. if the
make
health
sure
fair
that
had
peop
this
more
out,
people are aware of
you
what
know,
we have, and, yeah,
Had a flyer out, separate flyer, you know. Okay. I'm good.
excellent.
I want some of those flyers for me to hand out.
Flyers, check.
Check.
To, okay, done. I'll bring it out to your phone. All right, sorry. Okay, so moving ahead, thanks Stephanie and everyone. Just quick updates. You have a high-level update on your printout there, but I'll just give you a little more detail. We have confirmed the date, and through Christy Terry and her team, the health fair, the visual that you see on the left, that's a save the date that's available now. We're going to be pushing that out through multiple channels. What we have done so far is we sent a letter out regarding the event to all the elected officials, and we heard back right away from both the mayor of Caravel and Brenda Ash, the mayor here in Appalach. Mayor Ash has confirmed she's planning to be here. Several other folks have reached out asking questions, so that's great. We sent it out early, we'll send it out again. We're not really asking them for an RSVP, but if you do happen to hear from elected officials that they are looking to come or they have questions, please send them my way. So far, we have 25 health partners. Last year, we referred to them as vendors. Just personally, I'm offended by that word. When my clients call me a vendor, I really didn't like it, so I just evolved the language a little bit. So we have 25 registered health partners already. We have 16 responses still pending. So Craig, I thought maybe I would give you a list of some of the ones that are still pending because you were the personal contacts last year. I talked to you, Dan, already about one. But, you know, there's still time. And only 3 folks have declined. One is a new health and wellness retailer in town. They've decided they can't give up 3 hours from their store because they're a new business starting. So I offered to them maybe if they want to give us some collateral that we could share out. And then 2 others not available. Some of the new things, pardon me, that we're exploring as additions this year based on feedback from you all, the survey, and the staff and attendees is we're going to actually have, we're talking, thanks to Craig in advance, we're talking with some food trucks. We're trying to get food trucks to come in. There will be a nominal fee for them to have a spot on that day. And we've also encouraged them to think about adding at least one healthy item to their menu and proposing that $1 from the sale of each one of those be donated back to the hospital. So more to follow on that. Dead. We know that we attempted to have some entertainment last year, and at the last minute, Robin and her contacts came in with a DJ, which was great. We have time, and a special member of my team is on point for finding entertainment. So far, spoke with one group, they're not available, but we're on the hunt. Any update you want to give there, Mr. Zester?
I'm still working on that.
Okay, all right. And then finally, a new update. This came up in our hot wash meeting. I had asked Craig if he felt like, despite the great group of volunteers and staff that helped us set up this health fair last year, do we think we could use any additional, like, younger generation, healthy bodies to help us? And the idea was to reach out to the Beta Club. I did reach out to them. I've heard that not only they're interested in doing that, but they would like to also help in other ways. So set up, break down. They may have a table talking about their program. So the younger demographic is interested in getting involved. And then
Oh, excuse me, one thing, they were going to do an obstacle course
I'm
possibly?
just about to get to that. Thank you very much. Through Franklin County Schools, Candace Sheridan, who's the occupational therapist and the head, I guess, the sponsor for the Beta Club, she has offered for some of her folks to run the kids' games. And also they want to do an obstacle course for the kids. So that part of the health fair is shaping up great. We think that'll be a good draw. Maybe parents will come if they can keep their kids busy. That's really it. That's a longer update on the health fair than I planned. Any questions or anything anybody else wanted to add? No?
More to come.
Good. All right, so if you flip your page over now, I know the printout is a little dark, so I'll talk you through it. But essentially what we have done so far is we have secured the date. We did check with David and other folks to make sure that there wasn't anything conflicting with that date. The date was based on two things. We said we have our June 21st is the anniversary. We want to do this and do it well. We want to build momentum, excitement, entertainment. And then we needed to secure the big three, right? We all know from going to any event, wedding, or whatever, that some of the most important things beyond the people you're spending time with are the food, the entertainment, and the venue. So we needed to sync those three up first. Did that. We've secured an entertainment. We've secured a caterer who's donating 50% of their cost to our cause, and the venue. So the date is November 9th. Loosely, we're thinking 6 to 11. Doors could open at 6, then there'll be a silent auction up front, then dinner, then the entertainment will run from 8 to 10:30, and then we wrap at 11. Any questions? Okay, high-level detail. Sorry? Okay, high-level details, just so you know where we are. It's still obviously early in the planning phase, but we did want to make sure that our revenue or our proceeds exceed our expenses, so we've done some number crunching. As I said, we already have the hard cost estimates in from those three big ones. We've identified places where we can offset other costs through donations. We're targeting approximately 150 people. The venue it includes tables and chairs for up to 160 people. So that's included in our rental costs. If the interest in town or in the county exceeds that number, we of course can rent tables and chairs, but right now we're just working with that base number of 160 people. We've estimated what the working numbers right now is that the base, we'll call it the baseline ticket price, will be $100 per person. That'll cover catering, entertainment, and everyone will get a ticket for the door prize. The door prize, TBD, we're still working on that, but it'll be something that's valuable to anybody who comes. Sponsorship levels, we're thinking about 3. A sapphire, emerald, and ruby. Sapphire, dollar amount, we're still crunching the numbers on that, but we have some thoughts on that. But the sapphire would be a named primary sponsor of the event. They would get 2 tables. They would be lead promotion in the brochure that we're going to put out on the table. And then, of course, they'll get a gratitude announcement from whoever opens the event. Maybe they get a song of their choice from the band. Don't know, but that's working. The emerald would be the next level down. They would get 1 table and a half-page ad, and then the ruby level would be one table and you get a quarter-page ad. Any questions?
What are the proceeds from this benefit? Where do they went to? Who controls them?
Sure. So as I said up front, all the proceeds from any of the fundraising we do this year are going to come back to support outpatient services here at the hospital. We're going to have further conversation with David and Tom and the board. And how are they controlled? There will be no cash exchanging hands at this event. We're going to do everything in advance through PayPal, and it's going to go directly into the foundation's checking account.
What is the, let me, one more question.
Sure.
What type of funds are we looking at that it brings in to the foundation to be expended on the hospital?
It's a little early to say, right, because we don't yet know what kind of traction we're going to get. But as I said at the start of this, what we've looked at for our expenses, so we have estimates in from all the vendors that we know we need, and we're also getting donated fees and services. But our expenses, if we sold just 160 tickets at $100 a piece, we will cover all of our expenses and have, I would say, a modest level of proceeds to just back to the hospital. Does that answer your question?
Yes. Is this the first time this has been done?
It's the first time it's been done here, as far as I know.
Yes.
It's not the first time it's been done. My husband and I have been involved in them in other parts of the country. And I do actually have a couple people on our advisory board who have run galas in other parts of the country.
And we also do have who's the planner, the event planner.
So I have for the logistics, of course, I'm working with, any of you who have been in town for a while, maybe know Joanne McMillan. She's done more than 15 events at our venue. Our venue is actually the Coos Armory. We have the entire place. We can get in early on Friday for an additional cost. I don't think it's going to be necessary. She is deeply rooted in this industry. She knows many vendors, and she's already been negotiating for us.
And she's basically waiving her fee.
She's not charging us anything. The only thing she's passing along to us are out of pockets. No pass, all pass through, no markup.
I think this is great. Our Healthcare Foundation board at Weems years ago used to be very vibrant. They bought a lot of equipment for the hospital, and even during COVID time, although they were, really wasn't functioning well, they bought staff, masks. When we had National Hospital Week, which is coming up, they donated food. But the Healthcare Foundation is very important to a hospital because technically they can do a lot of the fundraising, the type of things that we really want to see. And I think the gala, the different things that will happen, the gala is just a start. And then next year we'll build upon that. But I think this is so great that they're doing this because we really need it, really.
Yeah,
so we're excited about it.
It's a really good point. This year we have 2 primary and 2 secondary events. We want it, like I said, we want to do it and do it well, right? Last year we helped support Robin and the team on the health fair, and it went well. Too few people knew about it and attended, unfortunately, but those who came were really pleased with it. So now when you mention the Weems Healthcare Foundation, people are aware of it. They're like, oh, it's back. So through some of these things we've planned for this year, they'll be well orchestrated. They'll make a positive impact. And then certainly as we get to like fourth quarter, we'll think about what are the things that we should add for next year. The only other thing I'll comment on the printout, it's very dark, I apologize. We are working with a graphic designer that I know from past life who's going to help us design, we'll call it branding for the event. So if you could see that, what you would see is that it's meant to just infer that this is meant to be elegant, semi-formal event. Somebody has asked, could I wear my tuxedo? Sure, if you want to. But it's going to be, that's the idea. More of it's a night out. The people that we've spoken to who are interested in donating beer and wine or services, they have said without solicitation how excited they are. They said the hospital, it's time for this, it's time for this for the town. So we're pretty confident we're going to get a good draw.
And I still got my daughter's wedding tuxedo I wear. I'm walking down the aisle with hope I can get into it. I'm really excited about this opportunity. Colleen, give some kudos,
Yes.
for the Healthcare Foundation. But we're really excited about the Healthcare Foundation here and where we're going with it. So I'm very excited about the opportunity.
Okay, so I think I took more time than you intended. My apologies. I talked a lot. That's talking Jersey girl. What I'm going to leave here for you on board, these are business cards. They have our email address and our Facebook information. What's most important is if you meet anybody who's interested or is asking how do I get involved in the foundation, just have them scan this QR code and I'll take them to a page that allows them to let me know that they're
Colleen,
Oh, yes.
let me take this opportunity to say thank you for, I'm over here.
I'm so sorry.
It's
Yes,
okay.
hello.
Thank you so much for spearheading. Are you the chair?
I am.
Thank you so
I have
much
a
for.
small but mighty team is what we're saying.
Yeah. So when you say advisory board, how many is on it?
Oh, there's 4 or 5 of us right now.
Okay.
And then we're bringing in volunteers for very specific aspects of each event.
Wonderful.
But if people are interested in getting involved, even if they just want to join a meeting and brainstorm, or they have ideas on anything and they don't want to commit more than just a conversation with me or email, that's fine too.
When you say elegant, that says all. Thank you for having this event.
Yeah, absolutely. Thank you.
Thank you very much. That was great. Thanks a lot. Next item is the medical staff report. Dr. Conrad, you can't beat that delivered right there, but give it a whirl. Dr. Conrad with us?
Dr. Conrad, can't hear you. Dr. Conrad, you may have to come back to you. You're off of mute, but we cannot hear you.
Dr. Conrad with us?
Yeah, we can't hear him, so we probably have to come back to him.
All right, we'll try to come back to him. Doctor, we'll come back to you, buddy. Can't hear you. Okay, the next item is clinical services report. Courtney Hoffman.
Texting me, so we'll see. That's what it says. I won't hook up. Not sure what the problem is, but you can see and hear it. You want to just call me? Hey, can you hear me?
Yeah.
All right, I'm gonna put you up to the mic, see how this works, okay?
Okay.
Okay, your turn. Go ahead.
Good morning, everyone. Sorry, I can see
Good
and hear
morning.
everything. I don't know what the trouble is. Can y'all hear me?
Yeah,
Yes.
we got you.
Okay. Quick rundown. Things are progressing along just fine. No big changes. Our X-ray reports have, on average, been coming in a more timely fashion, but that is almost completely due to Brian constantly nagging them, literally on a daily basis, to get things done fast. So much thanks to him. But we still have, still be looking forward to another bunch whenever that can happen. Staffing wise, we've gotten a little bit better, and that's mostly nursing staffing. We haven't had a doc staffing problem lately, but as that goes, so goes the number of admissions that we can do. We certainly can put some more swing beds in if we expand the staffing a little bit. Some nights we're good, but if we've got 2 or 3 swing beds in, then that limits the amount of acute care patients we have if we've only got 1 nurse on the floor. An ongoing challenge. We are seeing more clinic traffic in the ER, which is not a big deal. It just seems like there's a disruption right now with Dr. Newton and Dr. Sanala. So that will probably flatten out over time when someone is taking it back over the clinics position-wise. The hospice bed down at the end of the hall had some good utilization in January. I've talked to Mr. Walker about that. I'm really glad we've got that set up. And I hope nobody ever has to have hospice, but I think that is such an important thing that we offer here. We're perfectly set up so that locals can be near their family in a really horrible time. And very happy we have that. I hope we continue to utilize it as needed. Going down the road, this is not an urgent topic, I got a call a couple of days ago from a guy named Ed Mundy from ePowerDoc. Mr. Kozar is familiar with them. That is the system that we use at all of our other Southland facilities. I think it's a superior electronic record system to what we're currently using with Vetus. I used to be a big fan of Vetus, and on a continued basis, their system seems to have more and more difficulties the more they update it. And I told Mr. Mundy that our CEO, Mr. Walker, has that decision to make. I don't control the checkbook. That may be an ongoing thing to talk about as the dollars dictate. I'm not saying that's anything urgent, but just throwing it out there.
Hold on just a minute. David, could you paraphrase what, I can't hear that real well. That last part right there.
Can y'all hear me? Yeah. So Dr. Conrad was talking about the electronic health record that we use in the emergency department is ePowerDoc, not ePower, Vetus. And so he was saying that they may want to look at
transitioning to a new electronic health, which is called ePowerDoc. And that's something, we'll look at,
Okay.
maybe look at the cost of it, and then you're looking at the transition, because the physicians are comfortable with that and all that. So that's something.
Okay, all right, thank you. Go ahead, I got it now. I'm sorry.
Yeah, that was it. I was done.
Questions for Dr. Conrad?
No question?
Dr. Conrad, are we still looking to replace Dr. Newton?
I've got to kick that to Mr. Walker.
Yes, we are looking to replace Dr. Newton. Susan and I reached out to a physician the other day that may be interested in moving into the area, but we haven't heard. But yes, we are looking to replace, Dr. Newton here.
Mr. Chairman,
Yes.
I'd like to ask a question. Basically, I thought we already had electronic health record. And now you're talking about, and that system was brought in, if I'm not mistaken, by Alliance. Y'all directed us to that system. My question is, what does this electronic health record system do as compared to what we already have?
So the system we brought in was CPSI, and so that system, there's many other systems that have to merge, and it's not a one system handles every single thing in any organization. So with this particular CPSI, it does not handle the imaging component at all. That's not a piece of it, or the ED component at all. So there's a separate system that we have in the emergency room, and that particular system needs to interface with CPSI.
And so the interface has to be built, or just buy a complete new system?
Well,
I'm sorry, I'm just
no. And of course, we have, as Tom and David mentioned, CPSI is the main EHR for our inpatient, and it also handles our accounting and finance aspects of it. The one thing that CPSI is not good at is ER and clinics for documentation, ease of use. A lot of our Alliant hospitals have incorporated ePowerDoc for their ER system because it improves the documentation, its ease of use of the physician, so you can actually move patients through the system quicker, and it also helps with more accurately what we call leveling of the patient. So each patient that comes to the emergency room, they're typically assigned a level 1, 2, 3, 4, 5 to be able to determine the severity of their trip to the emergency room. ePowerDoc has actually generated additional reimbursement because of their ability to accurately document and charge for patients coming to the emergency room. CPSI, is a good system for what it is. But I can, from years of experience working with CPSI, there are two areas that they're not very good at, and why physicians and staff, especially in your clinics or in the ER, don't like it because it's very cumbersome, not easy to use, and so a lot of the hospitals have gone to this secondary system, which I would call as e-power doc.
Add to that, the ED system that we have currently now is called VITAS. So VITAS has been there for a while, right, Courtney, Dr. Conrad? And so we have VITAS, that's the electronic health record system there. The doctors, Dr. Conrad group, want to change to e-power doc, from VITAS. So we'll have to look at the analysis of it again, because when you do that, there's a whole lot of migration interfaces that have to be built for that. So it's two different systems there.
Is there a interface written so the two systems talk to each other?
Yes, I mean, because if you look at Calhoun Liberty Hospital in Blountstown, you look at Northwest Florida and Chipley, I'm not sure about Doctors Memorial, but our hospital and Eufaula, these are all CPSI-based systems that ePower has already built the interfaces into those CPSI systems.
Does that mean that we have to come along and put a bill for an interface between e-documentation and this CPSI?
Yeah, unfortunately, CPSI, no matter, and this is their business model, which I disagree with, but every time they put a interface in at a hospital, they do charge you, I think it's $10,000 to build. One-time charge to build the interface, to do it. Been a bone of contention for me because, they've already built this for Calhoun Liberty. They've already built it for Chipley. Why can't they just use that? But their business model is every time they do an interface for a hospital, they're going to charge you extra for it.
Then one more question, I guess, on that, since we're going down that road. So if we get rid of the Venus system, we go to e-power doc. Are they comparably priced? I mean, is it a monthly charge? Is it what are we looking at?
I think e-power doc may be a little bit more than Venus, but Tom, I don't know.
I don't have the exact numbers or anything, but ePower Doc, I believe they're right. They've right. It is a slightly more expensive system, but we want to make sure that more importantly, it's not so much more expensive that it's a move that you don't want to consider. You want to think about it from the perspective of the physicians that's using the system and making sure it's providing the tools and ease of use and everything for the physicians to be able to use more.
And Michael did mention that we may be able to capture additional fees that could offset some of that additional cost. Is that correct?
So I guess the bottom line question then is, was Dr. Conrad planning on interfacing these two systems?
Restate that question. I had a hard time hearing it.
He said, were you planning on interfacing those two systems, ePower Doc, to communicate? But it's not anything Dr. Conrad would be responsible for.
It's not anything Dr. Conrad is responsible for. It's the system itself. If you buy that system, there's interfaces that got to be built in, which they do it. Venus has an interface with CPSI as well. That comes with it, technically.
So prior to moving to something that we're going to be able to see all these costs.
Oh yeah. We'll get a proposal. We'll see the cost. We'll bring it to the board, technically, because if that cost is over, anyway, you have to make that decision. We want to go down that route.
Well, it's over 50,000. You have to go to the PUCC too.
Yeah. So it may not be. The last figures I saw could be a little less than that, but we'll look at that. But we'll bring it before the board, and the board can take a look at it as well.
Anything
it,
else?
Doc.
Okay. Thank you, Dr. Conrad. Appreciate it. Yes, sir.
Okay, I'm just going to talk quickly about our numbers because staffing is always an issue, and we did finish a contract with our night shift travel nurse, so she is gone, so that's one less night shift. But I moved a day shift full-time nurse to night shift to kind of accommodate and fill that gap. And then we have one night shift nurse who's PRN with us, but works about 2 nights a week, who's moving back home to North Dakota. So we'll be losing her on this next schedule as well. And I do have 2 nurses that in the last year left us for a different facility. They're coming back PRN night shift. So they will start on this one started this current schedule and one will start on this next schedule. So that'll fill in little gaps. So that is it as far as staffing. And the only other topic we have is swing bed, where I wanted to bring up Dan Paulson, who is our swing bed care coordinator. Oh, we did have the Mamo open house on the 27th. That went great. He probably passed all the pink balloons in the hall. So we had refreshments down here. We had a lot of the community show up. We were very thankful for that. Christy Terry from TMH was here, and she's posted some good pictures from that. So that was a nice event for the hospital, and we did our ribbon cutting, as you know, a few weeks ago.
Yeah, so I just want to just echo that because that was very important for us to have that here. You know, the ribbon cutting was great. We had Franklin Needs that was a part of that. We had the chamber come out, got some good press with that, and then we had the open house earlier this week, and we had a great time with that. So we had a lot of good feedback, and believe it or not, we had it from 3 to 5 o'clock, and the last person to come in, she was an official, but I won't mention her name, but it was 5 minutes to 5, but she wanted to see the Mammo room. Mayor Brenda Ash came in at that time and had a lot of good questions. So it was very good, you know, that opportunity that we have to provide services here. And I think one of the greatest thing about this, you know, we had testimonials. We had a young lady that I used to work with that was diagnosed breast cancer, you know, I think stage 4, I believe, and she was giving her testimonial during this time. It was very, very powerful. And that's the reason why we providing these services here to create access to care. And, you know, so that was, you know, we had some good testimonies of breast cancer survivors that were telling us about their testimonies there. So Courtney and her team did a great job. I just want to echo that.
Great, wonderful.
I did put that flyer also out on the next one.
Okay, yeah.
I don't know if it did any good or not.
Well, that's good. I put it on. I put it on next door as well. I got to get used to using that social media tag there. So yeah, and I'm just gonna put a plug in. Nextdoor is a social media app. So you know, if you all want to go in and you can still post some stuff, and I know Merce is on there now. I saw her name. And thank you, John, for posting that. Appreciate it.
So first I want to give a little introduction. You guys have heard me talk about Dan Paulson, who moved here and has been with us for a little bit now. He started working on the inpatient side and covering shifts because he wanted to learn the hospital and such. And he's done a great job doing that. He's also the one that I mentioned in the last board meeting that was very active in the hospice case here in the patient we had for 3 weeks and was actually asked to speak at the funeral. So that just tells you about his communication with the family and the patients. And truly, we are very blessed to have him here, working with our patients, working with our families, and he fits this role perfectly. So I'm going to turn it over to him now. He is our swing bed care coordinator. He's going to give a brief update on our swing bed for the last few months.
And Dan, also, as you're doing that, you can also tell them other things you've been doing, you know, community visits.
Certainly. Well, again, my name is Dan. I've had the honor of meeting most of you and even the privilege of taking care of some of your loved ones. I have been here about a year, as Courtney stated. This has been an incredible transition for me, having spent 20 years specializing in occupational health and industrial medicine, had the opportunity to come back and get into clinical nursing. So I've been able to relearn a lot. And I want to touch on something, Mr. Harrison, that you had mentioned a moment ago about traveling someplace else to get a service that you could have received here, specific to the ultrasound. I've discovered that you're not alone in that perhaps lack of awareness about what we are able to offer
if you think about Weems Memorial, what we have here is literally a hidden gem right here in Franklin County. A hidden gem right here in Franklin County, right here in Apalachicola, Florida. We offer an incredible array of services.
We do. You're right.
Not just 24-hour emergency nursing, not just quality inpatient care, not just the ability for folks that are dealing with end-of-life issues, as David mentioned, with our hospice room, but just so many other things. And in reference to Miss Christy Terry, who works with Tallahassee Memorial, she and I met earlier this week, and we talked about some of the approaches that we want to take to expanding people's understanding and appreciation for what we can offer here at Weems Memorial. We have, as has already been talked about, a state-of-the-art mammography machine. You will not find equipment like that anywhere in a rural hospital, anywhere in the southeast part of this country. Wow. You would have to go to Jacksonville. You would have to go to a university institution, a research hospital, to be able to find equipment like that. We have, as was mentioned, ultrasound. We have laboratory. We have radiology. We have CT. We have so many things that we can offer our local residents, and it's a matter of getting that word out. So I'm looking at it from the micro level, that is going to different providers, all the way to Panama City, up to Calhoun, over to Tallahassee, and of course right here in this area, meeting with individual practitioners and offices to explain to them what we're able to do. And I get a lot of the same thing. We didn't realize that you all had that there. And so as that awareness increases, we're going to see an increase in traffic. We're going to see people in our community who are able logistically to get the care they need here and not have to travel an hour and a half, or 2 hours to get what they could get right here in Apalachicola, Florida. I'm very thankful for that. When you consider the fact that collectively we have literally hundreds of years of nursing experience. I've been doing direct patient care now for almost 30 years. 20 years of that, as I said, as an occupational health specialist. But we have ladies here who have been doing patient care for 20 and 25 years in a variety of different fields. So we are very, very blessed to have what we have here in Apalachicola, and it's a matter of getting that word out to people. One of the things that we offer, what I have been tasked to do, one of the several things, is to increase our swing bed participation. And really, our numbers are pretty good. So far this year, we've had a total of 4 transfers from other facilities so that we could provide that transitional care. Admissions through the ER, we've had 3 so far in January and February. Those folks were admitted either for observation or for inpatient. Their conditions warranted that they needed a longer stay than what was initially thought. So we were able to provide them that transitional care. Total stay so far in this year has been 73 days of swing bed. And we attribute that certainly to our physicians who have been acutely aware of the conditions and the needs of those particular patients. And as well, the care that they have provided, the families have been convinced that they didn't need to go anywhere else, that they could get the type of care, the level of skilled care that they needed right here at Apalachicola and not have to go to Tallahassee Memorial, not have to go to Panama City. That being said, our physicians are also aware enough to know that when a patient's condition warrants transfer to a higher level of care, they react on that immediately. So we continue to be, and I think we always will be, patient-centric and patient-focused. And being able to do that shows to the patients on an individual basis and shows to the community that we are here for them and we are where they need to be as long as they need health care in this area. So our swing bed program is going to continue to grow as we're able to get the word out to folks and able to convey to specialists that when they have a hip replacement, a knee replacement, some other serious type of procedure, if the patient is getting their care at Panama City, at Ascension, at Tallahassee Memorial, they can, with all trust and with all concern addressed, they can send their patients back to us for that swing bed transitional care. Of those patients that we've had, we've been able to discharge them successfully and set them up with necessary home care so they get the care they need after they leave here. And thankfully, David and Courtney have allowed me the latitude to be able to continue working with these patients, to work with patients that are potential hospice patients. It is truly a privilege to be entrusted with the care of someone who knows they're going to be saying goodbye to a loved one. And folks know that they can come here and get that kind of care. I appreciate your time. Do you have any questions?
No, thank you very much.
Thank you.
Yes.
I have a question. Mr. Walker, I believe, in this situation. Can you briefly tell me with the REH designation and with the swing pad program, do the two go together, or do you have to exclude because of the more than 24-hour rule? Right?
Yeah. If the
So,
yes, what he's talking about, Mr. Bear is talking about, if Weems went to an REH designation, which is a rural emergency hospital designation, your inpatient care would go away, including swing beds. So that would go away. However, some hospitals, they are converting their inpatient unit to a skilled nursing facility. And Mr. Kozar can talk more about that. But right now, your swing bed technically will go away. All inpatient care will go away. You have your inpatient unit, not inpatient, you have outpatient, your ED, and you also can provide EMS, but you're correct. Inpatient swing bed will technically go away, but you can alter that unit to do skilled nursing. You want to?
And that's what I thought. I just wanted to make sure I understood it, because there's a passionate situation here that says, hey, we want these people to stay here in their final days, but it sort of contradicts the REH, if I'm not mistaken.
No, you're correct. And again, as David mentioned, that some hospitals, because the current regulations state that the only thing that an REH can have as a part of their organization is a skilled nursing unit, which eliminates swing bed and inpatient. But some hospitals are choosing to go, as David said, the skilled nursing route, where you could provide that swing bed type services in a facility if it's designated as a skilled nursing unit. So there is a way to get around that.
Providing the average doesn't go above 24 hours.
No. If you have a skilled nursing unit, that can, they can be in that unit for as long as they need it. You have to, as David just mentioned, you have to convert it and go through the licensure standards to be able to actually, it would be classified as a nursing home, but it's a skilled nursing unit that is able to provide rehabilitative services in the nursing home. But again, it would be licensed separately.
And it's not guaranteed. You still got to go through the licensure part of it. But you're correct. You're correct about swing bed and inpatient will go away. soon as you convert to the REH designation, as well as critical access designation will go away as well.
But we still have to talk about whether or not we want to take on that REH designation, correct? We haven't made any decisions one way or the other.
No.
And my understanding is there's the benefit with the REH is just the grant money that we would get from the state, correct? I mean, that's the trade-off that we're giving. But I think you have to look at whatever that grant money is versus what our swing bed money could bring in on the long run. So you got to look at the balancing act here. Is it better to have the swing beds and not the grant money, and then we could do whatever we want, or do we, switch to the REH and give up the swing beds and maybe get licensure down the road if possible? But that's a big if.
Well, and just to clarify, the way REH is paid is not grant money. It's actually funding from CMS to those facilities. What we will do, Alliant will do, is do a thorough analysis of the pros and cons. Because, some hospitals, it doesn't make sense because of what they'll be giving up is more than what they were getting from the additional funding through CMS. Other hospitals, based upon their situation, their volume, what services they provide, moving to an REH would be more beneficial. We would just have to do a more in-depth analysis of, what you get through DISH, LIP, all these other programs, and then, compare that and how does that stack up with what you would be getting through the REH. So it's not, a lot of times you hear that, okay, you're going to get this money, but you also got to account for what you're going to give up. The other big key thing in looking at this analysis is what are you giving up on your non-Medicare patients? Because, if you have a higher percentage of non-Medicare patients, you're going to end up losing more in some cases than going to an REH. So it's not as easy as saying, okay, here's $2 or $3 million you're going to get. You're going to be giving up other aspects of it too. So that's where that analysis needs to come into play so that you really have a clear idea and a clear reasoning going one way or the other.
And Michael, is there a time frame? Yeah, time frame. I'm thinking the same thing you are. Is there a time frame that we need to make that decision?
As far as the
going
government,
through the
no, there's no time frame. The REH started last year. Mm-hmm. It's now designation now. Technically, we wouldn't be able to move to it until the legislative session ends and they approve the ACA designation of that, because you still have to, the state, even though CMS has granted it, ACA has to have that category approved as a category of hospital. And that's, and again, David may be talking about this in his report, but it's moving through the legislative session. Everything looks like it's going to be approved. But you can move, once that is approved, you can move in at any time. There's no deadline. It's like when, and I've been in the business long enough to remember when critical access came about. It's very similar to that as far as the time frame. Once it's in there, it's not going to go away. It's just a matter of when is it going to be advantageous for organizations to move. Again, right now, and this is probably, this data is maybe a month or two old, there's only 18 hospitals in the whole country that have moved to the REH designation. Now, there is a number of people looking at it. We're working with a hospital in Tennessee that is going to go through that process, but again, you have to go into it with your eyes open, knowing what you're going to receive versus what you're going to give up.
I think critical access will be addressed. That designation will be addressed in this paper or this study.
Yeah, the critical access aspect.
Right. You have to give it up. I mean, that's
Oh, yeah.
Okay,
exactly.
So you have a situation today where you have critical access and you get the 101 or something like that on the billings. The question then becomes, are we giving up something that's really critical, quote, critical to us?
Oh, exactly. All those decisions, we will outline, that process and what you would be giving up versus what you would be gaining, and again, once you give up that critical access status, the only way you can convert back is if you meet the current standards, and the current standards is that you cannot be closer than 35 miles to the next hospital. So once you give it up, with Port St. Joe there,
Sick or hard to pick it up.
you have given that up.
We'll lose it forever. Let's move on, y'all. We're putting the cart. I understand. This is not-
I think Mr. Beer also wanted to know, maybe, do we have a timeline that we'll do the
Right.
analysis?
Did you have a question, Ms.
No,
Anderson?
I'm just looking for you.
Well, thank you very much for your time.
Thank you. Good presentation. Susie, clinical.
Good morning, everyone, and thank you again for your continued support with the Weems organization. So Weems Medical Centers are finally fully staffed after 4 years. So that's why I'm here today.
All right.
We were able to interview and acquire some of the medical professionals in the local area. As you know, Dr. Newton left, and Dr. Sinala closed his doors with Claire Spence. So we have taken on quite a few of those patients in the area, and we're happily doing that to become their primary care physician. So both clinics have taken that on. In light of that, we've also added on an additional provider, a PRN provider, to help with the growth, because also we have to accommodate for the walk-ins, as everybody says about walk-ins and the tourism. And to that fact, with the walk-ins, I'm always told that the clinics never do walk-ins or same-day appointments. But alone last month, we saw 120 walk-ins. Month before that was 112. I've been trending this now for quite some time, so I think there's a big misconception there. We do have, though, we are a primary care office just like anyone else, so we have scheduled patients, and if we can put somebody in the schedule, or if the triage is very urgent, we certainly will get them in. But we also have to accommodate our patients that have already been booked for a while. And that's also to speak to the effect about patients going over to the ER. That happens to be because of the out-of-state insurances dictate to them, and we give them a lot of that education before they actually call and say, out-of-state, call your insurance, see if you can see us, because their plans don't allow them to go to another primary care office. We're not an urgent care, we're not a minute clinic. So they tell them, we'll pay for your services if you go to the ER. And that's what they mostly see at the ER, or out-of-state plans. Or you get the occasional person that, well, I drove over from St. George Island, I don't want to wait an hour. Even though we try to tell them, hey, we have something in about an hour or two, they don't want to do that. So that's where that comes from. The other thing I wanted to point out, as far as an ultrasound or any services that you get in Tallahassee or Panama City, you can always ask, as a patient, your provider to redirect that imaging. I think doctors get into that habit, specialists get into the habit. It's an EMR system, so they have an electronic drop-down of the top 10 places that are local to them, and they just select it. Whereas a patient would say, hey, it's beneficial to me to go somewhere that's not going to be so bad. Right here in town is Weems Hospital. Okay, so that, as a patient, that's something we have to also identify when we're talking about advertising. Not just what services we have, but educating the patients of what rights they have. And we have been very proactive as looking for physicians. So we've talked to 3 lately, reached out to them, and it's a long process. So hopefully we'll get the right fit. In the meantime, Dr. Conran has volunteered to be our supervising physician of record for the insurances and the contracts. There was a little bit of
time frame crunch for contracts, but those are all being resolved. Heather Phelan's been fantastic with working with all the credentialing. So, we are going to look into some service lines with the new medical staff that we have to see if we can't do things such as laboratory services longer in the day so that patients that don't have to fast can come to the clinics and get labs drawn, and we can send it out the next day. So that maybe that's a time that would fit their schedule for work or school a little bit better. So that's what I have for now. Anybody have any questions relative to the question? No?
I just want to just say, Susie, of course, she's been on the front desk because she's been short-staffed so long. But there's a lot of different things we really do in our clinics. My goal really is to expand clinics, not only what we're doing now, but expand it throughout our county, technically. And so we're really excited about the staff that we have. We took on some of our staff, because we were short-staffed. But these individuals that we took on, they're very knowledgeable, very good in the community. So we're really excited about some things we want to do in our clinics.
Thank you.
Thank you very much. Take 5 minutes, gentlemen. Next, CFO report. Mr. Gibson had to go take care of a little situation there in the kitchen. You can give a presentation back. Tom Ramsey, CFO. Thank you.
All right. Good morning, everybody. So in your packet, you should have a set of financial statements there, specifically balance sheet and income statement. So on the balance sheet, first off, I just wanted to mention the cash balance for the hospital went from, it did drop slightly. It went from $2,033,000 down to $1,929,000. So, not a large drop or anything like that, but still, approximately 60 days cash on hand is where we sit still. With that, our AR has increased, our collectible accounts receivable, which is a positive, and that has to do an awful lot with the increased business that we've been seeing. And, when we get to the board dashboard, I want to kind of go over the different volumes that the hospital has seen with a comparison of what it was in 2021 year to date versus 22 versus 23 and now this year. I think it'll be interesting for everybody to see the progress that's been made at this hospital. On the liability section of the balance sheet, our accounts payable did drop slightly. So we went from about $630,000 down to about $590,000. So we continue to make sure our vendors are paid timely, and so that's a positive. Obviously, we pay when it's the most, we don't want to get penalized for paying late, but we don't want to pay too early. Either. So we do manage that outflow of cash accordingly. So on the income statement, you'll see. We ended up with gross revenues of $1.6 million, almost $1.7 million. For the year, we're at $6.3 million. We're up for the year $1.7 million more than we were last year at this point, year to date. And the year to date number is for 4 months, so it's through January. So we are in a fiscal year that ends on 9/30. So October, November, December, January. Those are the 4 months that
Tom,
the year is.
Could you just address maybe the ambulance revenue that's gone down? I'm wondering, just not that many people are being picked up, or we're not getting paid fully on all the calls, or what's going on?
No, these are gross revenues that you're looking at, so it doesn't have anything to do with what we necessarily get paid. But the volume of the calls have been down. Not considerably, but you can see it in the revenue.
Yeah, almost 150. Yeah.
Right, exactly. So, but it is interesting. That's one of the numbers that I'll show y'all when we look at the 21 through 24 analysis here shortly. So, but yeah, good point. So that was a good catch. Net revenues, they're up for the year $682,000, and that's completely related to the increased volumes that this hospital's been seeing and the efforts that the Heather and her team's been doing at making sure that we collect and get paid appropriately for what we're doing. Probably the biggest expense line for the hospital is always salaries. Salaries are up. Part of that is related to the increased volume. Part of that is related to the fact that we've done some increases for pay for areas that desperately needed it. And so, honestly, the salary number it's a pretty good number. Even so, we're going to work on making sure that all of our departments are staffed appropriately, whether that's increase, decrease, whatever. We want to make sure that we're taking care of everybody, appropriately here at this hospital, and we want to make sure that everybody has a job, obviously too. So,
do you think our salary is on a par with the rest of the area community? Are we up a little? Are we down a little? Or are we on a par? I mean, I'd like to see some kind of calculation of that, because you want to be able to, in this environment, you want to be able to retain employees, and if we're not paying what the rest of the area and the industry is paying, we're going to be hurting.
It's area specific to a certain extent. Some areas, we're more competitive than other areas. We've recently done some increases in the nursing area to try to make sure that we're more competitive on that front. I think we did a pretty good job on that front. Obviously, we're probably still a little lower than our most close by competitor, but we've made significant inroads on that front. So I'm pretty happy, and I'm assuming, Courtney, you probably agree to that. Yeah. So also, on EMS, for example, we've done some increases in there. Increases in there is to make sure that we can get our paramedics and hired and everything else, because there's a big shortage of paramedics, and so that was real important. And we're also looking at different scheduling models to make sure that we're taking care of the mental health of our paramedics and the team and everything there as well, because that can be a difficult area to work and everything. If you're putting in too many hours back to back, it can have an effect on a person. So we're trying to make sure that we're cognitive of all the needs of our staff throughout. So overall, our expenses are they are up about $738,000 for the year for operating expenses. So a lot of that is the salaries. Contract services are a piece of that also. Part of those contract services, a couple things. You've got your contract labor costs like nurse, agency nurse, things like that. You also have things like the collection fees that we pay to TrueBridge or CPSI for the increased collections that we've been doing. So that kind of plays a role in it as well. And pharmaceutical costs are up as well. And a lot of that pharmaceutical was that one patient from the past. But then in addition, it's increased volume. So you're naturally going to see increased supply costs, pharmaceutical costs, things like that as your volume continues to go up. Overall, we are sitting at a $709,000 net income, positive net income for the year to date. For the month, it was $228,000. You compare that to previous year, we were at $103,000 last year at this point. So we are definitely making inroads here. Like I said, a lot of this is volume related, and so it's been a good year so far. Any questions on the income statement?
Well, just looking at the income statement, I'm looking at last year versus current year, and the revenue section, inpatient revenue is what really drove a lot of that revenue volume.
Correct.
And that's key, $971,000 in difference. And I would assume that swing bed and some of the other things that we're doing have inpatient services here at the hospital, and that's one thing we certainly don't want to lose. I think.
So interesting. Our actual patient days, swing bed and acute, so the inpatient days, those are up 95% so far this year. So that's a big deal, almost doubled. Now the admits, they're only up slightly compared, but that just goes to the fact that we've been growing the swing bed program. The swing bed program has a much longer length of stay to those patients. So it really does come down to the swing bed program being that much more successful this year. And a big thank you to Dan and to Courtney for their efforts that they put into this. So, yeah, good question.
You know, because
It's really started. I mean, we've been focusing on swing bed, but now we have a dedicated person. So with, Dan, with, connection with Lori as well, you know what I mean? We're looking for that to grow. But a lot of the acute care, also people, coming here for a few days and leaving, maybe we can move them to swing bed after their acute care stay. So there's a lot of different moving parts to that.
Okay, with no other questions, I'm going to go to the dashboard report. So traditionally, I added a new section onto the bottom of this report for you all to be able to see, and I'm going to start at that section instead of the month-to-month view.
Where you got Tom? I'm sorry.
The dashboard report.
Okay.
So total net revenue. In 2021, this hospital was at $2.4 million. It's at $3.4 million right now. Every year, it's gone up just about. So you're at 2.4, 2.3, 2.7, 3.4. That's the trend on your net revenue. Cash is definitely up as well. I mean, we're up at 2.8. The next, even during, so 21 was really kind of a COVID year, the main COVID year. 22, 20, it was kind of coming out of the COVID. 23 still had a little bit of COVID in there, but that's the year we just finished up, and now we're kind of back on trend again. So, so even with the increased volumes that we did see in the COVID year, we're really doing extremely well. Our patient our patient cash collections up, our total cash collections up. Interestingly, our sales tax dollars are they're actually slightly down right now based on the actual cash coming in right now, and I know that's a seasonal thing, but when I compare those same 4 months to previous years, that is down slightly. Not to say that necessarily tourism is, but hopefully it's not. But we expect that tourism will continue to grow here in this community and will help support those dollars as well. So on the volume side, so our admits are at 30. I'd mentioned it was only slightly up over last year. 29 is where we were last year at this point in time. But like I said, the days are up 95%. That's not on here. I did a quick calculation of days before I came up here, and it's up about 130 days over last year at this point. So, we're at 255 days. We were at 126, I think, is what it was, the number of days last year that we were at.
That was the base number?
Yes. So it's a considerable increase.
And what do you attribute to
Swing bed primarily. Yeah. I mean, acute days are up as well. It's not just swing, but primarily swing is driving it.
Yeah, because you look at the data that we looked at last year, fiscal year. I think we were like 195% higher for swing bed into the fiscal year. In 23 fiscal year end September 30th. So that number will continue to grow as well. Just amazing when you see those numbers grow.
Maybe if you added another line to that and put days in there, that might be a good thing for us to look at.
Sure, absolutely. I'll be happy to.
Yeah, that'd be great.
So the other items that we kind of look at as kind of a driving, main overall arching volume number to kind of see in general where things are going. The total outpatient visits. So they've gone from 21 through 24 at 648, 623, 888, and now we're up to 1,101. So, really, if you look 2 years, 3 years ago, we're almost twice what we were at on the outpatient side as well. So, you know, that's a big deal. People are coming and utilizing this hospital more, and we're, you know, it's because of the good service that we do provide here at this hospital. Emergency room visits, they are up from 1,363 back in 21 up to 1,730 this year. This is the highest year in the 4-year trend. Our billable ambulance runs, to your point earlier, you know, we are at 401, and last year we were at 441. And the year before that, we were at 450 and 421. So this is the lowest year on our billable runs that we've had. You know, I'm not really sure what to make of that at this point because it's based on calls and things from the public. So, you know, I know that we have a top-notch program with the EMS. I mean, we've got great paramedics. I don't think it has anything to do with that at all. But those calls are down. So maybe we're a healthier community now than we were. I don't know. I'm just speculating. Clinic visits. This is an interesting one because clinics kind of drive where the hospital's going ultimately. You know, the higher your clinic, the better your clinic does, the better the hospital does. So in general. So it's jumped up to 1,966. Last year it was at 1,847. And so, you know, we're continuing to grow. And this number through January, this was really before we have absorbed a lot of patients from Dr. Sanala's office. You know, Dr. Sanala's increased business that we're starting to get is going to be based, we're going to see that in February, not so much in January. So, you know, we're really seeing, you know, everything kind of grow in the right direction at the hospital, from volumes to revenues to collections. You know, our patient care levels, even if you look at things like up a little farther, we talk about fall rates, and it's a quality indicator. We didn't have any falls this last quarter, none. You know, which is a big deal. You know, we don't want patients to fall, but, you know, I mean, it does happen in hospitals at time to time. But we didn't have any. Our average ER emergency room turnaround time for a discharged patient from the time they come in to the time they discharge is at 100 minutes. That's really good. That's real positive. We typically run right around 95 to 105 here at this hospital. So
I got a question, Tom.
Mm-hmm.
The chronic care management program, which we just mentioned, we have 50, 06, 21, 50. Is this sustainable, you think? Or we don't do it?
Yes, it absolutely is.
It's not just I mean, it's going to be sustainable.
It absolutely. It's actually, I got an email this morning telling me where we were as of today. It's actually up to 62 now, so it's continuing to grow.
Okay.
So these are the total number of people enrolled in the program.
Good.
So it's positive. It's really going well, and you know, a lot of Dr. Sanala's patients, from what we were hearing, actually participated in a chronic care management program with him at the time. With him leaving, I'm sure, you know, we'll pick up those as well to make sure that we continue the care that they're used to getting as well. So, you know, we want to make sure that everybody's taken care of. So yeah, good question. Anyway, are left without being seen rate. So I did want to talk about that real quick too, because it's 0.7%. That is a patient that comes into the emergency room and they, just before they can be seen by anyone, they decide they're going to leave. So, you know, you want that number to be as low as possible. I think the benchmark number, correct me if I'm wrong, Michael, but I think it's 2.3% is the benchmark for that. You want to be under, and 2%, yeah. So we're at 0.7%. And it could be for a number of reasons. You know, I would speculate that 9 times out of 10 for this hospital, it's not because they have to wait a long time. It's maybe because they start feeling better. But at any rate, it's not that high. We're doing a really, really good job here at this hospital, and we should all be proud of the team we have here at Weems. Any questions on that? Okay. One last thing I did want to mention, we are going through the annual audit right now with Carr-Riggs and Ingram as our audit firm, and they are, so we're working through that. It's going very smoothly. Heather and Samantha, they've been providing all the information to the auditors that they've been asking for, all the samples that they've been pulling and things like that. So my conversations with the audit team, Brian Hall and his team, have been positive. We feel pretty good about how the audit's progressing at this point in time. Any questions? All right, awesome. Thank you.
Just to point out on Tom's sheet, mammographies to date, up through January on the sheet there, we have 65 memos, and I'm trying to find out right now, of course February ends today, how many we will have before then. So mammography is really taking off as well. I like that.
Better than I thought it was doing, early junk. Okay, Craig, you back?
Yeah, I'm back.
You solved that problem, right?
I solved that problem.
Okay.
Yes, sir. Good morning.
Good morning.
I'm just going to give you all a kind of a light update of what we've been doing as far as maintenance. We've cleaned the roof. It hadn't been done in about 2 years, and every time you'd step up there, you would kind of slip and slide around when we'd go check out the units. Now it's clean and it's been sanitized, so it'll kill that algae that grows like we have here real quick. I've got a couple of exercises for the department managers coming up. March 6th, we're going to do a virtual chemical tabletop exercise. Now, the likelihood of us having a chemical spill here is not very likely, but several years ago, we did have a spill out here at the water treatment. They had chlorine. So we'd rather be ahead of the game than not. Then March 7th, we have a continuity of operations planning workshop. This is through the Florida Healthcare Coalition. Both of these are, and it's just going to help us comply with the ACA requirements of having these drills. We'll be having several other drills all during the year. We have to comply to 2 federal and 2 state. So we'll be doing those, and I'll put those out there as we get through with them. We have installed the signage as you come on the properties at all the facilities about being aware that you are video surveillance as you're here. They've been put at both clinics, 2 at East, 2 at West, and 2 here, and I've got some more that we're going to make more visible here at the hospital as well. We now have a lawn service that's going to be taking care of the grounds up here. They do the lawn service over at East. They do a really good job, and so it takes them about a day because they come over here and knock it out. And with just me and Troy, it's taken us about 2.5 days to get it done. So we've got them. They're going to be starting cutting about twice a month now with the season fixing to grow. They also do the trimming of the palms and things like that as we need. I'm currently working on the names of all our staff members that are out of Apalachicola so I can get them their re-entry tags. So when the disaster season comes up, I'm going to go ahead and pass that out so we're not hurrying to get that. They'll keep those until the end of the season, and then they'll turn them back in too. So I'm working on that right now. I've gotten 3 departments so far.
Hey, when you get everybody, if you live somewhere else, somebody that works in the hospital, I mean, was that?
Well, that's our hope. They get the re-entry tag that we have in Apalachicola. Like we have people who live in East Point, Carabel, but it's not a guarantee they'll get back in because we don't know what the roads are going to look like.
Yeah, I guess, you got a good working relationship. I'm sure they know the hospital before it comes.
Yeah, hopefully so.
Yeah.
You would think we would get back in with our band.
Yeah, I think we will.
I would think so too. let's see. Starting next month in our QAPI, we're going to have what we call a safety huddle. And what this is for it's not just safety of our facilities, it's to report on any safety issues that anybody sees, is to report any deficiencies with our equipment, and so on. But it'll keep everybody informed, and then start a process of getting this stuff fixed, in a timely manner. So I think it's going to be a lot better for us as far as safety too. Both clinics, we have removed all the TMH signs. They're gone. Over at the clinics, I do a monthly rounding. It's about 26 items for each clinic that I go through: doors, locks, miscellaneous lights. Everything's working over there. I do have worksheets every month that I create if we have to have something done over there. And then I'll let Susie know about it also, so we're on the same page. EMS, I've only had one call for them to repair something. And what we do is EMS station in East Point, and all it was they had a water leak in the ceiling, and I called their landlord, and he had the roofer go over there and take care of that. And he said when it rains again, for us to call him back as soon as it does. If they have a leak, they want to get the roofer back over there to check that out and make sure they get it done this time. All right. Any questions?
Yeah, busy, aren't you?
A lot more than this. I'm just giving you a highlight.
I have one question.
Yes,
please.
ma'am.
How many custodial staff do we have?
You mean as far as maintenance? Or, housekeeping?
Yeah.
We have 2 full-time and 1 part-time.
Okay. So would you say that's enough for when we have patients that their rooms are cleaned every day?
We try to get that done every day, but what happens is the ER gets busy, and we have to go take care of that, clean that room in between each patient. So sometimes we do get backlogged, and I haven't had any applications here lately for that. And actually, my part-time person for housekeeping has actually been helping me in the kitchen since we're short-staffed there as well, until we get our 2 other dietary people back.
So what I'm hearing is that we need another custodial housekeeping person.
A person, yes. Yeah, we do. And I'm constantly looking. We got it out there in our, I think on our Facebook, Robin. Yeah, we put that out there. Yes.
Thank you.
Yeah, you're very welcome. Thank you. Anything else? Okay. Thank y'all.
Okay. Walker, you.
You all see there's a lot of things happening at the hospital. A whole lot of stuff that is going on at the hospital. So this is some information I want to share with you all as part of my report. Okay. Can you hear, Kristen? Okay. There's a whole lot of activities happening at the hospital. So you all heard that. First of all, before I get started, I want to recognize Murtis Wynn. Murtis was presented an award from the Franklin County Sheriff's Office as the Community Service Award for all the things that she does in this community. So Murtis, we greatly appreciate that you're a part of our team.
Well deserved. Well deserved, too.
Thank you for being a part of our team.
That's right.
The first,
You got to give a 10-minute speech now,
the first thing I have is a board action item for vote. We have our Weems holiday policy. Our Weems holiday policy, and what we had to do, we had to update the dates for 2024 to match the policy. So technically, it's the same policy, it's just that New Year's falls on a different date, than, maybe Martin Luther King on a different date. So we just had to outline the dates of the policy here. And so we just need a vote for that. In the policy, you should have the policy. I think y'all have
all
it.
you're talking about is change the date.
Yeah. Yeah. Isn't that right, Robin?
Gotcha.
Yeah, so basically we have edited the holiday policy to reflect the Weems paid holidays for 2024.
Mm-hmm.
We just,
date for the holiday.
yeah, we just need governing board approval for that.
Do I have a motion to approve this?
Motion.
Second. All in favor?
Aye.
All opposed?
Second, this board information items. Many of you heard Mayor Mayhew speech presentation to the Board of County Commission earlier this month. She came and she did an excellent presentation on the state of rural health care statewide. The County Commission next steps will be to schedule interviews with healthcare consultants to determine what will be next for the future of Weems in healthcare services in Franklin County. I was not at the meeting, but I know some of the board members did attend that particular meeting. And we will continue to find out what the County Commission is doing. And my hope is that the County Commission and the hospital board will work together as one, to work towards a common goal, for healthcare services here in Franklin County. So I just want to just update you all on that. Like I say, Mary Mayhew came down. You all heard her speech about that. But I think the county next steps, from what I've read and saw, is to interview some healthcare consultants. I don't know anything further than that, but I just want to make sure you all have that information. There was also an article that was sent, Attorney Michael Schuler sent the Board of County Commission about future rural hospitals. And basically, I sent this out to all of the board members. And this article, simply indicated the high percentage of rural hospitals in the nation that are in danger of closure. The article indicated that 41% of Florida rural hospitals are at risk of closure. Rural hospitals have been closing for a number of years now. I've always said that the pandemic kind of sped that process up a little bit. And so, but that particular article is out there. The same information that Mayor Mayhew was saying prior, to her visit about, the danger and the constraints of our hospital system. Not only rural hospitals, but
I got a question. Are we one of them 41%?
I don't know. I didn't see the
It's
percentage.
easy to write an article and throw these percentages around. You're not telling me anything.
I didn't see that.
I read that article, and it's the same thing you can read.
I don't know.
47,000 different articles.
Yes,
Are
I
we one
don't.
of the 41%? No, I don't think we are.
Yes, I don't know. I'm just bringing it to your attention because you got it.
David,
Yeah.
I'm not.
Yeah, but other thing too, with rural hospitals, you never know because it can go up and down.
I know.
Technically, all the things, the challenges that we're facing, in the rural hospitals, areas.
That's difficult to understand.
It's difficult.
I'd like to know the 41%.
Of all those hospitals, 41%, how many of them have a health? I mean, I keep hearing that all a healthcare staff, okay. I keep hearing all this. I just don't want to go there because I feel bad. The heavens are falling.
Yeah.
But are we not in a better position because of the fact we have that reserve there? And I mean, we can expend a lot of energy worrying about this and that, but we also don't want to give up that capability to have that extra support, out there. And I hear the 41%, and I hear all these numbers, but I don't see how that really affects what we're doing.
Yeah.
I think we need to be conscious of it, realize it's going to be a struggle. Not a struggle. It's going to be a lot of hard work and some expertise involved. But if we go in, this board goes in the attitude, well, it should close down, and we do get the county stuff, which was voted on by the county residents there, and that helps. But that's not the only thing people are talking about the close. And I think we're better at the close. I just like positive attitude. I agree with you. You say the sky's falling directly up. An acorn don't hit you on the head, you're going to crawl under a rock for the next 3 years. I'm just not like that.
But I think you're right, and I think what's really positive for this organization is our numbers, and their numbers are trending upwards. When we looked at the financials here, and we look at the numbers of inpatient, outpatient, swing beds, we're putting forth the best possible results for our organization by having these outpatient programs, by having these swing beds contribute to the bottom line, and the bottom line is moving upwards for us. I mean, talking about having 700,000, revenue or profit at this point in the year versus 100,000 last year, we're in a lot better shape than we were. And I There may be people failing out there, but they're failing because they're not watching what they're doing, and I think we are.
Well, if I could just add that, where you see the hospitals that are really failing, one, they have no community support or tax support to do the hospitals. A lot of the hospitals, especially rural hospitals, and I go back to a statement I made earlier in the meeting, is when critical access came along, a lot of these hospitals chose not to go that route. And I can probably name 2 or 3 that that have reached out to Alliant, for help. But when they had the opportunity to move to critical access, they thought, no, we're fine, we're good, we're going to be what we're at. And now they wish that they would. The other thing to Bill's comment is the hospitals that are failing is also you don't see the upward trend in volume. You don't see that positive movement in both utilization, volumes, revenue that you're seeing here. So I think, all in all, the outlook is so much more positive than some of these other facilities throughout the country.
Yeah, and I think in the data, you look at the data, like we said before, let the data begin to drive you. Next, we have the legislative session going on. Mike Kozart talked about it earlier. Of course, we have 2 priorities, the rural emergency hospital designation, which is moving through the legislature now, and then we have the capital improvement recurring funding, that we is advocating for the legislature to give us. And in your packet, I have 2 letters here that at the last board meeting, we decided that the chairman would draft a letter to send to Representative Schoaf and Senator Simon. So just take a look at that for a moment if you like. This is what we're going to send to them. If you have any additional things you want to strike out, put on, just let us know. We would do that. And one of the things that the chairman wanted, he wanted all the names listed so the senators and the representatives can see your names on this particular letter, because it's a joint effort. That we're asking them to continue to advocate for funding for the rural hospital program.
Y'all look at that. Are y'all okay with that?
Yeah.
We made it brief, but we just want to know we're out here and thank you.
Yeah.
Without getting into a lot of detail, and I did look at all the board members because people won't vote. Some people have names there too. If we're going to send that off today. If it's okay with y'all. John, you read them over right quick. You read over the letters right quick. The letters that we're sending, that I'm sending out.
Right here.
We discussed it last meeting.
Yeah.
Just a little brief letter thanking our and they've done some hard work over there too. Really, they've done some good hard work with the funding situation.
Yeah. And so we'll continue to monitor that.
No, somebody wants, we don't need to vote on this.
Yeah, because I think last meeting the board decided to send a letter.
Decided to do it, and I'll just get the letter. Y'all just look at it, got any changes or anything, and we'll be happy.
And then the next
So,
item.
let's just go ahead with the meeting. Don't get a chance. Don't take a vote.
Yeah, we don't have to take a vote. I think at the last meeting you all agreed to send a letter, so we'll go ahead and go with the meeting. If you have any changes you want to add, let us know. We can do that. The next item, we had our Health Resource Service Administration host a mock 340B audit by Blue & Company. So we had a young lady come down that we worked with. She looked at our 340B claims. She also gave some good recommendations. How can we expand our outpatient medication ingestion services to create access to care for individuals who are traveling out of county? Susan and Courtney is working on that initiative. And what we have now, we have some people that have to go to Tallahassee to receive an injection, or Panama City, because we don't offer that service here. So we want to make sure we begin to offer that, service at this location. And what would happen is that it will enhance our 340B program. Also in your packet is a copy of the logo of our 65 years in existence. The staff at Weems picked this logo out. We had a vote and they said it was kind of fervent about their logo. So that was good. We wanted to get the staff involved. So 65 years Weems have been here, and we'll begin to put this logo out on a lot of different things that we're doing. We've already discussed the Memorial Tree open house.
Dave, can we go just to the logo for a minute? Are these two separate logos, or is this going to be?
It's going to be it's one logo.
It's going to be combined.
Combined. Yeah.
So we took that little wave thing that used to be on the George Weems Hospital, and we just moved it down to the 65.
Yeah. And this came in horizontal, and we did it in both ways, vertically. Okay. And so it just came out big on here, but I wanted to make sure you all got a copy of that as well. Lastly, not lastly, but the last item, we talked about our organization chart here, and what I've done, I've updated it to show some reflection of the county commission connection, to our organization chart. And so, at the top, I got Franklin County Board of County Commissioners on that, and then the governing board. Then under the governing board, we have the chief executive officer. I put Alliance Management Services so we can reflect that as well. I know on the agenda we were talking about the bylaws. I don't know if you want to move to that next step because not the bylaws, because I want to make sure I mention
The bylaw.
yeah.
Oh, yeah, well, I talked to Mr. Barone, and gave him the recommended changes, and he's given that to the county attorney to look at it, do something with it.
So Michael Schuler, the county attorney, has the bylaws right now.
He's got them right now, so it'll get the commission, and I'm sure the changes will be fine. He might have to add something else, that's up to him.
I just wanted to say that while I was standing up here, because I know that Michael Kozar is coming next, but I didn't want to get back up back and forth about the bylaws. Anybody got any questions?
Can we, I think we probably need to go over the letter. Okay, there's a lot of prepositional phrases that you start the sentences and so forth. I think we probably need to rest that out a little bit.
Okay. Well, we'll do that, and John, we'll get with you after that.
It's not a good point, but the other side is that it says that they understand prepositional phrases. I don't even know if they teach those anymore in school, right? So, I see it.
All right, well, we'll get with you and Robin and Connect. We'll get that taken care of. Okay. All right. Anything else? And we have Michael Kozar up.
I just have two quick things for the Alliant report, and one of the items is that this year Alliant and working with all of our hospitals, we're establishing some specific goals that we want to accomplish along with the on-site team here at the organization. It doesn't change anything that we're currently doing, but looking at specific areas where we could work with the on-site team to continue to make improvements with the organizations. And that could be in the, finance area, it could be in the quality area, it can be in operationals. And we will be coming back at the next board meeting with a list of goals that we're going to engage, Alliant's going to engage to try to specifically work with at the hospital to continue to make the improvements that the organization needs. So, and again, what I try to stress for our team, it is not where we have these goals and we pass them off to David or to the team here and say, okay, accomplish this. This is actually where we, as Alliant, are going to be working with that team to make those improvements in the organizations. And I'll use one of the areas because you guys you're doing really good at it, but some hospitals aren't. Is falls, patient falls, and where Paula Moore would actually work with the clinical team here and try to implement actions that are going to prevent patients from falling in the organization. So, and that's what I mean by goals. As you know, we're going to look at specific things. Tom could be working with somebody on the days accounts receivable, and how are we going to bring those days accounts receivable down. I could be working with David on strategic planning or strategic initiatives, but we'll establish for each organization, you know, some specific goals that we want to try to accomplish this year, along with everything else that we provide for the organization. Because again, I think it's important that we continue to look at how do we make the improvements in the organization, and what can we be doing as Alliant to assist the team doing it. And again, I want to stress the fact that it's not going to be, okay, Alliant says, David Walker, you need to do this. It's Michael Kozar and David Walker sitting down and saying, okay, let's come up with a plan. How are we going to address this issue? So moving forward, we're trying to roll those out with all of our organizations.
You're going to target some areas.
Specifically
Oh,
target, yes.
That works good.
And then it will be, and again, you know, it will be us working alongside with the on-site team to make those things, accomplish those things. So we're excited about rolling this out. I think it will continue to demonstrate and bring value to the organization of, you know, some of the things that we learn from other organizations, and how can we translate them specifically to you know, to Weems Hospital here.
Michael.
Oh, I'm sorry.
I would just say, don't be afraid also to utilize some of the skills of people on this board.
Sure.
As far as their abilities, and if there's some goal or thing that you want to work on, and it dovetails with our skills, we'd be glad to also pitch in, not just management or administration, but you know, tag the board as well.
Well, and again, it's really looking at how do we pull that team together, you know, to be able to accomplish some of these, you know, what we would call operational excellence initiatives, so that we can really start making, you know, some positive movement in not just, you know, finance or not just operational, but, you know, how can we also work on improving clinical quality? Is it, you know, another aspect, and I'm using an example that we rolled out, and we did roll it out to one hospital already just to see how it would go. You know, one of the areas is how do we reduce employee turnover? What are the things that we need to be doing with employee turnover? You know, it's not just salaries, and it's not just, you know, paying somebody more. It's how do they value their job? What recognitions are being done for when they do a good job? Those kind of things that are going to encourage people to say, hey, I really get benefit out of working at this organization far beyond, you know, the dollar amount. You know, looking at not only retention, but what are we doing to recruit also? Are we working with the local community colleges? Are we working, you know, one of the areas that's really in demand, and I don't know the status here, is lab. You know, lab technicians are extremely hard to find. They're as hard to find right now as nurses are. But what are we doing? Are we working with the school systems? Are we working with, you know, middle school, high school? Are we trying to encourage people to go into these areas? What are we doing? So it's more of a broad range of initiatives we would do. So the second item that I just wanted to mention, and we talked about this I think at the last board meeting, or one of the previous board meetings, I should say, is that we talked about the Medicare Advantage underpayments, and that's where, you know, we know, and I've learned a lot over the last 6 months on this topic, is that, you know, what we're seeing in organizations is that, and especially with critical access hospitals, that sometimes your rates change on an annual basis based upon your cost report, that the Medicare Advantage plans are not paying what they are It looks, very promising. This hospital that we used as a pilot, they've identified about $1.5 million for that hospital. And what's more important, 1.5 million. Pardon? That where the Humanas, the Aetnas have underpaid what they were obligated to pay the organization, and what makes this difficult is that you have to go into each patient's account and basically look at what was charged, what was the contracted amount that they were supposed to pay, and then what they ended up paying. And so what has taken us so long is then we're specifically working in this pilot one with CPSI, where they've actually gone into the system, are able to get the 855s, the EOB, match that up with the patients, and then to be able to extrapolate that out over, what the payment should have been. So I'm hoping within the next 45 days that we will be able to get this finalized, so then we can sit down and see how do we roll this out to all of Alliant hospitals, because again, $1.5 million for this organization is significant. And that goes back to 2019, where they've been able to go back and track.
Michael, are these Medicaid payers or healthcare programs? Are they just not paying what's due because of paperwork issues, or they are just shorting people for the hell of it?
Well, I'll give you a prime example. Every year when we do our cost report, our outpatient rates are set. And it could be, and I'll use this other hospital we're doing a pilot at. 1 year their rate was 20%. The next year it was 19%. Then it went up to 24%. And then it went to 28%, which is all good for the hospital. Medicare is paying us accurately. But the Medicare Advantage plans, what we found is when they changed that, they didn't change the rate, the Medicare Advantages, and so you're sitting there supposed to be getting 24%, and they're paying you at 20%, and it takes and what makes it complicated, because we'll get an EOB, explanation of benefit, or we'll get a check, and it may have 10 patients on there, 10 patients, 10 different patients. And
so they're not breaking it all down
so
individually.
you have to break it all down by each patient to do it.
We don't have enough staff.
Nobody has enough staff. Teammates or Gulf Coast or Ascension, they don't have enough. But by using this technology that this company's developing, is enabling us to actually where they are in CPSI system now, and they can pull that data out of the system and then break it down by patient, by insurance carrier. So then we can go down and sit down with the insurance carriers and say, here's 35 patients that you underpaid us. We expect payment on you. So, but again, I wanted to give you an update on it. We're not quite finished yet. I had a meeting with them last week. We've gone through the data is pretty impressive of what they're able to gather. So we hope to be able to sit down with a spreadsheet to Humana or one of the other Medicare Advantage plans and say, here's the documentation on how you underpaid us.
And just remember, I was reading an article. Medicare Advantage. They have a three-part goal: to delay. They want to delay payment, then they will deny the payment, and they don't want to pay the payment. So that's what they do. They'll delay when you put a bill in. They'll try to delay it, and then they'll do a denial, and then when time runs out,
They'll pay a partial.
and not pay it all. Yeah. So this is going to be real good. But, you know, yeah, so I guess once we look at our numbers, and let me just give you another example. You know, a few years ago, we did an analysis of when I first got started here. I was saying that I probably used the word I probably shouldn't have used. You know, that we was getting, I said, raped by these insurance companies because they was paying us pennies on the dollars. We sent a termination letter to one of the biggest insurance carriers that we had, and that was a couple of years ago. And you know, one of their lobbyists, you know, met with one of our past state legislatures and saying, why this small hospital don't want to do business with us anymore? And she said, because you all are not paying them right. Yeah. And so, but they needed us in network, and then they raised our rate. You know, so that was one of the largest that we had here. But we had to go through some of that, but it's for years. So just imagine when you're providing a lot of service and you're getting paid below the Medicare rate or the Medicaid rate, you know, you cannot get ahead. You know, so that's some things that, you know, we had to kind of do here.
Well, you know, there's another thing that I'm not sure which Advantage plan is doing it, is now putting more obstacles into even being able to file claims. And I just was reading an article earlier this week where they're going to make, and using a physician office as an example, that you're going to actually have, that physician's office is going to have to do a triplicate filing to be able to get paid for a claim. And it's going to have to go to specific different areas in their company. And if it's not accurate, they won't pay it. Or if it's not sent to all three of those places, you're not going to get paid. But it's these hurdles that they can consistently do to us. And then you look at the salaries of the executives that are on Humana and Blue Cross and Aetna, they're the ones making money. United is the other big one out there, So, and I didn't even touch upon the other aspect that this program is looking at is what they call the rounding. The rounding, where you'll have that amount, and they'll typically round it down. So they save a few dollars here and there on every claim just by rounding it down, and you're not actually getting paid what you should be also. So.
Is there anything that can be done about that?
Well, I think that.
Can we publicize it? Can we go to our?
Well, I think we do need to publicize it. We do need to always identify and let the public know what difficulties we have in just getting paid for services that we're doing. But the challenge that we have is that Medicare Advantage is becoming more and more popular because you turn on the TV anytime in the fall and you see Joe Namath and you see all these other ones and saying, I got the Walker guy. I've seen them on the TV saying I get this stuff for free if I sign up with United.
You're right. They're selling the advantages to the people, and they're saying, hey, we can add a dental plan, we can do eyeglasses, we can do this, that, the next thing that your regular Medicare can't do. But in the long run, they're able to provide those services because they're not paying on the basic services.
Right, exactly.
Which is the problem. And your guy that came in at the conference that talked about the programs and the differences and whatever, I thought he was fabulous. And when I had to sign up for, I just went with the regular Medicaid. I didn't take any of those advantage plans because of what he said in his presentation. I thought he was great.
Well, and if you all recall that presentation, really, his prediction, and this is not mine, but this is coming from that presentation, that we're going to end up in the future with we won't have Medicare anymore. We will just have 2 or 3 of these advantage plans, and they're going to control all the health care in the country. all I have.
I got one more question. It's back to insurance. I know we review our contracts every year now with the hospital insurance. So I remember one time that they weren't being fair with us. Working with the hospital. I know you got 11 hospitals, 10 to 11 hospitals. So you've got a good picture of what we should be reimbursed. I'm talking about my contract with insurance. Right?
Yeah.
I know we went through this. There was some.
We do. We do. Every state is a little bit different. It's hard to say that because Illinois pays here that Florida should pay there also. Because you got a lot of the state plans and things. But in general, yes, we do. In fact, having 4 hospitals here in Florida, we have a good feel for it as well. Absolutely. And we do have a good individual that works here with us at this hospital to negotiate the contracts that used to work for Blue Cross, as a matter of fact. So he knows the ins and outs and secrets, and yes, absolutely.
So if I understand it correctly, when all said and done, this company, well, whoever will be able to take the inputs from the record, medical record, put that in there automatically with an interface, and then turn around and come back in with what you got for payment by the codes, and somebody's written this software again, and then they're going to come along and be able to tell you the delta of where you got shorted, all automated, but they haven't told you how much it's going to cost them.
Well, we haven't worked through that yet. I mean, I'm just being honest with you. And it's more likely it's going to be on a contingency type of basis. Where,
they want to bite of the apple.
Well, whatever they find, it's typical that they're going to say, if we find X of dollars, we want a percentage of that. I'm just being honest. We haven't worked through what the cost would be, but that's probably what I anticipate we will find.
I like that better, because if they do find us $1.5 million that we weren't going to put in our pocket anyway, giving away 10% of it's not a big deal. Exactly. What I don't like is if they charged us a monthly fee every month and didn't find any money.
Yeah.
I'd rather have the former.
Yeah.
We work hard at it. Bet.
So you're going to share that result of wherever the pilot project is, so we can see the breakdown.
Yeah. And like I said, I think in the next 45 days I should be able to come back to you and say, okay, here's beta site 1, and this is the data they were able to pull, this is what they were able to do, and then we can see about how do we roll this out.
And whose platform is that being developed?
It would be their platform. It's Lockbox platform.
And are they tied to Alliant in any way with regards to if Alliant were to leave, we would lose that service or anything like that?
No, they're not. I mean, they're not currently now they're successful. Would I like them to be a part of us? Of course. But no, right now they're not. There's no connection between Alliant and Lockbox. It's just a company that we came across that was developing this, and we partnered, to be able to give them the beta site to look at this.
Evidently, that swing bed is the lifeline.
Yeah, I thought I gave that report last time. Yeah.
I didn't see the number. I haven't seen that report.
Well, I think I verbally gave it, but I can get it to you. I can get you through all of last year, of the numbers and the breakdown by, I mean, I have a breakdown by hospital, how many.
Right, you were gonna come back with a report that showed us how much we benefited.
Yeah.
Like that, or we
Exactly.
benefited.
Yeah,
from it.
I can get that, I can get that for you. I thought I gave that
And
already.
secondly, there was, part of that was supposed to be activity sheet, basically, what our persons are doing, who they're meeting with.
Our stuff, Dan, he can shoot a report to y'all about that, what he's doing. So we're developing a report, and what we'll do, we'll just send it out to you as well, so you can take a look at it to see if it meets your expectation, per se. But for the swing bed thing that Michael has for Lori, that's a regional part. They do stuff as well, but we will have.
That's what I'm talking about.
Oh, you talking about that?
That's the one that's really the activity driver, if I understood it correctly.
Yeah, there was a total of, I think amongst the 4 hospitals, there was a total of
And
1,200 days.
I remember that. I remember that portion of it, but that didn't specifically address our situation.
I think I have it broke down by each hospital. So each hospital, how many admissions they had, how many swing bed days they had, what the revenue generated from those swing bed days equated to for each hospital. So I have
And one other measurement is how many of those that we got were generated basically by our own self-efforts.
Yeah, well, again, I think what the report I have is the ones that Lori facilitated getting here. Now, the hospital here will do what they did on their own, from their own basis or their own community. That data that I have is what Lori Franklin, the care coordinator, brought to the organization. And they would predict you what the numbers are from generated here.
Dan has that information. So
Okay. You're gonna make changes in that letter, right?
I didn't know I was deciding to make
No, you
changes.
said
All
it
it
was-
is grammatical.
You said it was, you said it was some, problems with the letter we're sending.
It's grammatical. It's just basically it has a
But,
number of
you want to
prepositions.
change it? I mean,
I'm not an English.
No,
well, you said there was a problem with it. I mean, I thought it looked pretty good.
I'll be happy to look at it.
I can look at it later.
Okay, well, let's get it done, get it ready. All right. Anybody got anything else? Okay, meeting adjourned.